So let's continue our topic on anti-rheumatoid drugs. We have already discussed the methotrexate and the non-biologicals. So today we will discuss the biologicals, the biological DMARDs. The biological DMARDs, we have these. These are basically the monoclonal antibodies or the recombinant proteins or the tumor necrosis factor receptor proteins. So what these drugs do, they inhibit the cytokines which are mostly involved in autoimmune process like tumor necrosis factor alpha and interleukin 1. So because they inhibit these cytokines, they are therefore beneficial in various autoimmune diseases like rheumatoid arthritis, inflammatory bowel disease, psoriasis, and scleroderma. However, they do produce very prominent adverse effects and they are also very expensive. So therefore, they are the reserved dose for severe and refractory cases of rheumatoid arthritis. So first drug is the tumor necrosis factor receptor alpha inhibitors. So what these drugs do, they prevent the binding of tumor necrosis factor alpha with the tumor necrosis factor receptor 1, which are present on the T cell and the macrophages. And because the T cell and macrophages are unable to stimulated by the tumor necrosis factor alpha, so what happens, the further cascade of inflammation will not take place and therefore they are beneficial. So when this inflammation does not take place, therefore the inflammatory changes which occurs in the joints of rheumatoid arthritis patients and also the new regions which are being produced in the rheumatoid arthritis patient, they are decreased, they are slowed down, and they are very quick response than other non-biological DMARDs. They are usually added to the methotrexate when the response is not adequate with the methotrexate. They are also used in very rapidly progressive cases of the rheumatoid arthritis. However, these biological agents, that is the TNF alpha inhibitor, they do increase the risk of opportunistic infection like tuberculosis and pneumocystis pneumonia. Another drug is the etanercept. Etanercept is basically the fusion protein. So when this drug is given, they prevent the binding of tumor necrosis factor alpha with the tumor necrosis factor receptor. They basically do combine, they sit on the receptor, they do the fusion of the tumor necrosis factor alpha receptor with the Fc portion of the immunoglobulin G1. So when this binds here, the tumor necrosis factor alpha is unable to bind with the tumor necrosis factor receptor, and therefore the T cell is not stimulated and further inflammatory process stops. This etanercept is usually given as subcutaneous injection 50 mg weekly. However, they do report the side effects which are usually the injection site pain, redness, itching, and swelling. They also increase the incidence of chest infections. The dose of etanercept is 25 to 50 mg subcutaneously once or twice weekly. Another drug is infliximab. This drug is basically the chimeral monoclonal antibody that bind against the tumor necrosis factor alpha, and therefore the tumor necrosis factor alpha is unable to bind with the receptors on the T cells and macrophages, and further cascade of inflammation will not take place. The dose of infliximab is 3 to 5 mg per kg, and it is usually infused IV every 4 to 8 weeks. The side effects are usually the fever, chills, urticaria, bronchospasm, and rarely anaphylaxis. They also increase the risk of chest infections like tuberculosis and pneumonia. They also worsen the congestive cardiac failure. This infliximab is usually combined with the methotrexate. When combined with the methotrexate, there is improved response to the treatment, and further they also decrease the antibody production against the infliximab when combined with methotrexate. Another drug is adalimumab. This is recombinant monoclonal antibody against the tumor necrosis factor alpha. The dose of adalimumab is 40 mg subcutaneously every twice weekly. The side effect is the injection site reaction, and the incidence of chest infection is also increased. Similarly, when they combine with methotrexate, the response is there is improvement in the response, and also there is decreased production of antibody production. Another drug is interleukin 1 inhibitors. They basically inhibit the interleukin 1. These drugs, the drug in this group is anakinra. These drugs are less effective than tumor necrosis factor alpha inhibitors. They are usually used when more than one DMARDs fail. The doses of anakinra is 100 mg subcutaneously daily. The side effects are the local site reactions and chest infections. The drugs include, we have the abatacept and rituximab. They basically inhibit the T cell and B cell respectively, and they are used for refractory cases of rheumatoid arthritis. Now we will talk about corticosteroids. These corticosteroids basically has very potent immunosuppressant and anti-inflammatory activity in rheumatoid arthritis. They can be used at any stage of rheumatoid arthritis along with first or second line drugs when we require a very potent anti-inflammatory action. They provide the very fast symptomatic relief. However, they do not arrest the rheumatoid process. However, with the corticosteroid, joint destruction slowed down and also the bone erosions are delayed. However, with the long-term use of corticosteroid, there can be very serious adverse effect as they can increase the blood pressure, they can cause the diabetes, they can cause the peptic ulcer disease, as we know. Therefore, when they are used either as low dose 5 to 10 mg of prednisolone, that usually supplement the non-steroidal anti-inflammatory drug. However, with this manner, the withdrawal becomes very difficult and the exacerbation can be precipitated, and the patient usually becomes steroid dependent. Another method of administration is you can give the very high dose corticosteroid over a very short period of time until the DMARDs take their action. They are usually given at high doses over a short period of time when we suspect very severe manifestations like organ-threatening disease or vasculitis. For single or few joints involvement and with severe symptoms, we usually give the intra-articular injections every 4 to 6 months. In this manner, steroid offers relief for several weeks intra-articular injection, and joint damage is slowed down with intra-articular injections.